Hello and welcome to the Highlights podcast, summarising the key messages from our recent webinar, Advances in the Treatment of SLE. I'm Ed Vital. I'm Professor of Translational Medicine and a rheumatologist at the University of Leeds in the UK. And I've been joined today by Professor Cynthia Aranow, who's a Professor of Medicine and Director of the Clinical Autoimmunity Centre of Excellence at the Feinstein Institutes of Medical Research in New York, and also Professor Richard Furie, who's the Chief of the Division of Rheumatology at the Department of Medicine in Northwell Health, New York, and Professor of Medicine at the Zucker School of Medicine. Hi, both.
Hi, thanks for having us.
Hello, Ed.
So what we're doing here is recording a highlight of the content that we discussed in our webinar done on the 7th of April, which was chaired by myself and with presentations from all three of us. And our topics include the key immunological mechanisms of lupus, talking through the different targeted therapeutic approaches for those mechanisms, advances in the treatment of lupus and the challenges of patient outcomes in clinical trials. So you can access the full on-demand webinar and all our detailed discussions at www.lupusforum.com, and you can watch that for free. So without any further delay, I'll hand over to Cindy. Could you give us a summary of what you presented?
Sure. So, as you just mentioned, the first portion of this webinar focused on some of the key immunologic mechanisms of lupus and then targeted therapeutic approaches. And so, we reviewed many of the recognized abnormalities of the innate and adaptive immunity. So, in summary, the protective immune response, antigen is processed by antigen-presenting cells. It's presented to the T cells, which then interact and activate B cells, furthering their differentiation and maturation into antigen-producing plasma cells. And in lupus, autoreactive B cells are not deleted. They are around, and this pathway results in production of autoantibodies. And we've known for many years that autoantibodies can cause injury by a number of mechanisms. They can bind directly to cells. They can form immune complexes, which can become stuck in tissues. They can activate complement. They can activate cells, neutrophils, and components of the innate immune response. We also, and this has become clearer and important, that in addition to serving as as antibody producers, that B cells can activate T cells so that B cell T cell activation goes both ways, and this amplifies the immune, but in lupus, the autoimmune response. And so this suggests an additional pathway by which B cell directed antibodies may function, because in addition to depleting B cells, they may inhibit the B cell maturation and facilitate differentiation of autoreactive B cells. In terms of T cells are different in lupus than in normal controls. They provide excessive help to autoreactive B cells. The T-dependent B cell activation requires antigen-specific interaction of the T cell receptor with the B cell and MHC, but it also requires a second signal. And recently, the interaction of CD40 and CD40 ligand has become increasingly important and interesting to rheumatologists. Lupus T cells are skewed towards pro-inflammatory states. There's increases of Th1, increases of Th17, and this is a fairly new finding, and the decrease in Tregs. And IL-2 production is actually lower in lupus T cells, and IL-2 is really important in terms of Treg function. And we also touched upon the role of interferons. This is the innate immune response, and plasma and dendritic cells, plasmacytoid dendritic cells, which make, as I was once taught, bucket loads of interferon, and that the interferon and the upregulation of interferon regulated genes has clearly been demonstrated in lupus patients, clearly has an important role in terms of both pathogenesis and sustaining lupus activity, and that this suggests a potential therapeutic intervention. And even though there are 13 different types of subtypes of interferon, all subtypes bind to the same interferon receptor. So this is also important. Another pathway that's become of interest is the JAK-STAT pathway, which we know that plays an important role in resisting infection, maintaining immune tolerance, immune surveillance. So just a reminder that the JAKs are a family of intracytoplasmic enzymes, tyrosine kinases, which associate with cytokine receptors. So what happens is that the cytokine binds to the receptor, it activates the JAK, which then activates the STATs, which then translocate to the nucleus and regulate gene expression, so that in lupus, when the interferon binds to the interferon receptor, it then results in signaling to the nucleus, and the JAKs that are involved are JAK1 as well as TYK2. So as we learn more, we begin to identify new targets for new therapies. We also gave an overview of existing standard of care therapies, as well as some of their limitations, and a reminder that there are only 6 drugs that are currently FDA approved for lupus, and those include 3 that were approved early on: aspirin, hydroxychloroquine, and Plaquenil and steroids. And it's only since 2011 that we've had additional drugs approved. Those are belimumab, both general lupus and lupus nephritis, anifrolumab, and voclosporin. But patients will often ask, well, there are only 6 approved. Why am I being treated with X, Y, or Z? And as I have said for years, rheumatologists have begged, borrowed, and stolen from medications from other medical specialties. So there's much more in our armamentarium than just the currently approved drugs for lupus. So the current EULAR guidelines for treatment of general lupus include hydroxychloroquine for all, steroids when needed, and that the doses should be limited to either discontinuation or a dose no more than 5 mg per day. And regarding the DMARDs and biologics, that the punishment should reflect the crime, that we clearly tailor the type of amount of immunosuppression with the DMARDs and or biologics to the degree of lupus severity. And importantly, there are only 3 biologics that are currently included in the current EULAR recommendations, and those are belimumab and anifrolumab for second line, mild disease, moderate disease, as well as initially for severe disease, and rituximab for severe disease. Recently, the ACR guidelines for treatment of lupus nephritis were released. It's not yet published, but should be pretty soon. And these are more aggressive than things that were previously published and recommended, in that triple therapy is now recommended at the get-go. So triple therapy means steroids with glucocorticoid pulses, followed by a rapid taper of oral prednisone to, again, no more than 5 milligrams a day by 6 months. And for proliferative nephritis, triple therapy preferred is the steroids plus mycophenolate plus belimumab. And for class 5 nephritis, steroids plus mycophenolate plus calcineurin inhibitors. So, these are, so the therapies that we have, are still limited. There's still, much that we need to be that needs to be developed. We currently have limitations that I think stem predominantly from the heterogeneity of the disease and the heterogeneity among different patients. So not all patients respond to therapy because the underlying pathways are likely different among different patients. Patients may have some patients may have a complete response to some medications, but other patients may only have a partial response, even though they have a little bit of a response. And different features of lupus are going to have may respond differently to a different agent. So lupus nephritis is clearly a class of its own, but skin disease may respond differently to an agent X than joints, and hematologic manifestations may respond yet differently. So, I mean, there's a lot of heterogeneity in terms of the disease and the disease features itself. Another issue that I think we've all seen is that patients may initially respond and then they lose that response, so that we have to put them on yet another immunosuppressive, and the patients then are cycling through the laundry list of the medications that we have, and that list is not unlimited. There are also limitations of safety with increased risks of infections, cancer, infertility, and the side effects of steroids are well known and are certainly associated with accrual of damage. So, I mean, I really think that as we're looking to go forward, we really need to be thinking about changing our emphasis from global immunosuppression to that of a more targeted approach of that focuses on the biology and focuses upon the biologic mechanisms, and that we need to be thinking about well, we don't. Okay, so we need to be thinking about biomarkers because we need to be thinking and moving towards precision medicine, but we're not yet there. And identifying the mechanisms in different that are functional in different patients is really going to pave the way for new and better therapies and new and better outcomes.
Thanks. Yeah, I really agree that the immunology is just complex, and we used to think it was kind of more simple, that it's B cells and it's antibodies, and the more we understand, the more complex it gets. But then at the same time, whilst that's getting more complex, sometimes it actually helps to make things simpler in understanding why lupus looks like it does. And so in my presentation, I tried to then go through some of the different strategies that can be used to target all of these different processes that you just described, because the number of therapies in development is really, really broad. We didn't have time to talk about even half of them, but we talked about the most important ones to illustrate those points. And there's loads and loads in early phase and fewer as you get to later phases. So just to go through a few of the highlights of that, belimumab, we all know, targets BAFF, but there's a next generation of drugs that more comprehensively target that system, because that system involves BAFF and APRIL and three different receptors. And so targeting all the different molecules involved may be possible and maybe better. That's drugs like povetacicept and telitacicept that do that. Then the other way to target B cells, you've got B cell depletion. So we all know that really well from rituximab. And I think what most people appreciate actually now is that we used to think rituximab killed all the B cells. But now we understand that actually it doesn't. It doesn't to kill them all, particularly within tissues and things, and that might be why it doesn't work. So again, you've got a next generation. So there's a drug called obinutuzumab that recently had a positive phase 3 trial for lupus nephritis and is expected to be licensed for that indication. And obinutuzumab, it still targets CD20 the same as rituximab, but it has a different killing mechanism that's more effective. So it's a better form of B cell depletion. And other drugs in development like ianalumab also has this more potent method of killing B cells, but it has a different target, because it targets the BAFF receptor on the B cell instead of CD20. So it's a kind of like a combination of blocking BAFF and depleting B cells with the same drug. That one's just a little bit further behind, still in phase 3 trials, good data in Sjögren's too. So the ways that we can target B cells look more interesting. And as we said in the Q&A, there's CAR T therapy and bispecific antibodies too. But that's all adaptive immunity. And we've got innate immunity too. As you said, interferons have so many effects in the immune system and aren't just produced by blood immune cells, but are also by all the tissues. So the target organs themselves are making the interferons. This is the kind of part of the pathology that might not be reached by targeting B cells with however deep you go. And so we've got anifrolumab already licensed that targets the interferon pathway. We've got litifilimab, a drug that targets PDCs to try and stop them producing interferon, although how that relates to the other sources of interferon needs to be understood. And we've got the JAK1 inhibitors and the TYK2 inhibitors that block more like the signaling of the type 1 interferon, as well as some other cytokines. So we've got adaptive therapies, we've got innate immune therapies, and they might work for different things in different patients, which is something we need to explore. And then there's the mechanism of action that's kind of newer, perhaps to a lot of people, that we talked about in more detail, was about CD40 ligand. So this is a co-stimulatory molecule. Abatacept blocks co-stimulation, which is B cells and T cells talking to each other. They need co-stimulation to do it. So there's abatacept that blocks CTLA4 and CD28. Another one is CD40 ligand, and that's blocked by a new drug called dapirolizumab. And again, it's following the same theme that we used to think we understood things quite well, and then they just get more complex all the time. CD40 ligand turns out to have really many, many more roles in the immune system, on all the different cells of the immune system, dendritic cells, the different T cell subsets that you talked about, Cindy, and on monocytes and macrophages, and also even on some of these kind of non-circulating cells that have immune functions, like epithelial cells in the kidney and in the skin, can be involved with CD40 ligand signaling. So it's an interesting target in that it might hit lots of these bases at the same time. So that drug has just been through a phase 3 trial that was positive called Phoenix Go, which is a trial of patients who mostly had skin and joint disease with a bit of other disease activity, and it met its primary endpoint of BICLA and several of the secondaries. So differences seen with SLE4 and bilag flares and steroid tapering and so on, with really no really substantive safety signal to be concerned about. So that trial, Phoenix Go, is complete, reported. Phoenix Fly is in progress. That's the follow-on phase 3. So that's one that people may be interested in referring their patients for. So yeah, I mean, really, I think the summary again follows on from the same point, is that the immunology is complex. There's lots of different things going on and lots of different drugs being developed to target all those different things. And we're starting to see more positive trials. And then we'll have a challenge about deciding which drug when, how to make every patient better with hopefully a whole repertoire of therapies at our fingertips. I'll hand over to Rich now.
All right, so my presentation was about the challenges confronting lupus clinical trials. And the fundamental question is, if we understand, or at least have a better understanding of the pathogenesis of lupus, why don't we have more drugs? Well, anyway, lupus clinical trials are very challenging. I divided my talk into 3 areas: the complexity of clinical trial design, and then number 2, outcome measures, and finally, the barriers to success. So I'll just give you a synopsis of those areas. For trial design, there are not too many options in lupus. So the first order of business is to distinguish between SLE trials and lupus nephritis trials, because obviously the treatment algorithms are very different. And then within SLE, decide between whether you want to focus on a single organ domain, for example, skin or joints, or whether you want all comers with multi-organ involvement. And though it seems like single organ would be very easy, very homogeneous, skin disease is not as homogeneous as you think. And we have additional problems with musculoskeletal manifestations. Arthritis comes in different varieties in lupus, some I think more responsive than others. With multi-organ domain involvement, you're dependent upon SLE and bilag, and certainly there are idiosyncrasies, and those idiosyncrasies are not solved by the composite indices, the SRI and the BICLA, because those are dependent upon SLE and bilag. Now, there are new outcome measures that are being developed. We also have the lupus low disease activity, LLDAS state, and the DARS remission, which maybe someday will be recognized as primary endpoints by regulators. So we have issues with outcome measures, no question about that. I stress the difference between, say, SRI and BICLA versus LLDAS and DARS. The former group being a reflection of improvement, and the latter group achieving a particular state of benefit that is good for a lot of different things, certainly less damage accrual, and the list goes on and on. So improvement versus an absolute state of well-being. And then I finished up with barriers to success. I'd say the biggest barrier to success is our high placebo response rate, and there are a lot of different reasons for that. I think we need to enroll patients who are very informative, who truly have high disease activity. And it's harder and harder to find those patients because of our approved drugs, belimumab, anifrolumab, and the use of approved off-label therapies. So I don't know how to address that problem. I think the population of high disease activity patients is in fact shrinking, and that will make it yet harder to do trials that are dependent on designs taking high disease activity to lower disease activity. But there's a bright future. There are so many drugs in development, and we will see more approvals, and that just means better outcomes for our patients.
And I think it is positive because I feel that in the past there were some instances where trials were negative and we didn't know whether we 100% believed it or not. And there were some times when we turned out to be right, to be skeptical because another trial came along with a different result or something like that. But I feel now that the trials are getting better at telling us the truth. That good drugs do usually succeed. Would you agree?
Oh, I definitely agree. So we've learned the hard way.
Yeah.
So we've, I think, made our entry criteria a bit more restrictive. We are very careful about background medicines and tapering of steroids. So I do agree with you.
And I guess with your respect to your last point is that are there enough patients out there? I guess I think what I always say to people is it's important to still realize the value of trials. Just because there are options in the clinic, patients can do really well in clinical trials, and the whole experience of being in a trial can be a very positive one, and I really encourage people to refer for them. So I think that's all we have time for. So thank you very much, Cindy and Richard. I hope this highlight summary was useful. Remember to have a look at www.lupusforum.com to have access to a variety of content like this and keep an eye out for future webinars. Thanks for your attention.